you have just been given a very big award. I think of you, I think of BCOP, this very important regimen for Hodgkin's disease, and a whole lot of other things. But what do you think the EHA is remembering you most for when they're giving you this prestigious Jean Bernard Lifetime Achievement Award?
As I said in my thanking words, maybe two things. One, that I'm one of the still living old pioneers of Hodgkin's disease. And the other is that I was a bridge person between laboratory and clinical bedside at the patient. And we started out with Epstein-Barr virus and found that it is absolutely a tumor virus in Burkitt lymphoma in Africa, but we didn't know what it does in Vienna or in Philadelphia at this time. And we knew that it is a virus coming from a tumor. Therefore, we tried to transform normal lymphocytes. And I used umbilical cord blood cells, and I put it on the tumor cells of Burkitt lymphoma patients. And the virus was transferred, and the cells were immortalized. And this was in 1966, the first time that human lymphocytes were immortalized. And this is with EBV, with Epstein-Barr virus.
How did that join up with the Hodgkin's disease work?
At this time, not at all. We later found out in Sweden that Hodgkin's disease is connected with Epstein-Barr virus, and about 50% of the Hodgkin patients have in their tumor cells the gene of Epstein-Barr virus, but 50% don't have it. That means possibly there's another ubiquitous virus that can cause Hodgkin's disease, but we don't know it. Harald Stein, the Nobel Prize winner, and I have tried to find this virus in our tumor cells in vitro, but so far we haven't yet found it.
Now, for some time, BCOP has been the leading sparring partner to ABVD in Hodgkin's disease therapy. Both have achieved amazing results.
Yeah.
What gave you the idea of generating BCOP?
We were not excited about ABVD because if you give in advanced Hodgkin lymphoma stages ABVD 6 or 8 times, you get about 70% progression-free survival, but 30% will relapse or progress. And we were not happy with that. Therefore, we tried to increase the density and intensity of ABVD or whatever. At this time, it was COP ABVD. So we put it together, and it came out BCOP. And we had a mathematical model, and we could show that it is 10% better than ABVD. And then we did this study, and it worked. And BCOP is a very aggressive but very effective regimen that is used mostly in Europe. And we have about 90 to 95% tumor-free survival after 10 years without using the transplantation that you have to use in about 30% after ABVD. And autologous transplantation is expensive. The patient doesn't like to have a relapse. He wants to be free of tumor. They say, Dr. Diehl, you are very nice, we love you, but we don't want to see you again. So they don't want to have a relapse. And therefore we use the BCOP, but BCOP is too aggressive.
Right, and thereby hangs a tale, because BCOP is now changing.
Yeah.
And can you tell me what it's changed to and what difference this is making?
Yeah, when you ask me what is the most important invention or happening that occurred in my career, then it is most probably that with Harald Stein, my pathology friend, we found the CD30 antigen on the tumor cells, the red stomach cells. And for 30 years, we tried to sell this monoclonal antibody that we produced against the red stomach cells, but nobody wanted it. And the company said, well, it's nice, but it doesn't kill. So there came a chemist from Seattle Genetics, and he put a bomb on the CD30 antibody with a linker. And then this construct with this bomb, auristatin, goes in the tumor cells. It is released, the auristatin, and kills the red stomach cell. And since the Reed-Sternberg cell is keeping up the environment alive, the whole environment, even in kilos of relapsing tumors, disappear within 14 days. And therefore, brentuximab vedotin is a new agent, the new magic bullet that already was asked for from Ehrlich in 1928. He wanted to have a magic bullet that you don't need radiotherapy and chemotherapy, and you get rid of the toxic effects, acute and long-term.
But now, BCOP is changing. Can you tell me what is happening?
Yeah, we are happy with the efficacy of BCOP because it induces 95% of complete remission and 90% of tumor-free survival after 5 to 10 years. But it induces also toxicity, and this is leukemogenesis, it's infertility, and it is long-term toxicities, cardiac and pulmonary. Therefore, we decided to use the new antibody drug conjugate brentuximab vedotin, put it in the early induction therapy, BCOP, and out of BCOP became BRECAT. BRECAT means brentuximab vedotin, etoposide, cyclophosphamide, adriamycin, and instead of procarbazine, we give tarcarbazine, and instead of prednisone, we give dexamethasone.
Meanwhile, what's happened to the whole ABVD side of the story?
The ABVD side of the story is changing also because they're using brentuximab vedotin now, and they leave out the bleomycin and give AVDA, adriamycin, Velban, dacarbazine, and brentuximab vedotin, Adcetris, it's called in America. And AVDA is now tested against ABVD, and it seems that it is very effective and less toxic than ABVD.
Finally, what do you advise doctors to make clinically of these very interesting developments?
Both the AVDA using brentuximab with ABVD or BRECAT is not yet on the market. It is in clinical studies. There's an Echelon-1 study ongoing with Takeda, and we will start next month the BRECAT study with Australia and some European countries. And in about 2-3 years, we can tell you whether we can stop BCOP, and we will have BRECAT and AVDA.
Now, very, very briefly, could you run me through the numbers? How much of an improvement in therapy for Hodgkin's disease and preservation of the reduction of long-term toxicity might this all mean?
AVDA, they want to go from 70% complete remission to 81%. For us, it's not enough. We need 90 more, 95. BRECAT will have about 90% complete remission induction and about 40% only toxicity. That means half of the toxicity, but the same efficacy with BRECAT.
Could I, though, ask you about Novolup?
There are 2 studies that were reported at ASH 2014 by Ansel and Moskowitz. This is one of the new drugs that activates the T-cell response to tumor cells. Novolup is an antibody that inhibits the programmed death interaction between the tumor cell and the T cells. So if you inhibit that, then the T cell will be activated and kills the tumor cells, with the result that you have about 80% of response now without even chemotherapy.
Could you potentially use nivolumab together with brentuximab?
Possibly this will be one of the studies to have this cocktail. And I'm sure that already some studies have started to do that and leave out the chemo and radiotherapy.
So what's your takeaway message for doctors?
The takeaway message is use ABVD in early stages, possibly leave out the bleomycin because we have shown that AVD is as good as ABVD. and use in the very aggressive advanced stages, use 2 courses of BCOP, escalated, then make a PET. If the PET is negative, go to ABVD. If there is a very aggressive advanced Hodgkin, use BCOP all the way through. And wait till we have AVDA on the market and BRICAT or AVDA.